Hello, today we will start obstructive lung diseases. We will take two obstructing lung diseases, bronchial asthma and bronchiectasis. By the end of this lecture, you have to know the definition of both topics, bronchial asthma and bronchiectasis, explain the pathogenesis of each one, describe the pathologic features of each one, recognize the clinical picture, and list the complication of bronchial asthma and bronchiectasis. First, we classify the diffuse lung diseases or diffuse pulmonary diseases into two main categories. The first one is the obstructive lung disease, which is increased resistance to airflow due to partial or complete obstruction. The second category is a restrictive, which is reduced expansion of lung parenchyma with decrease in total lung capacity. So we have two main categories of diffuse lung diseases, obstructive and restrictive. The obstructive lung diseases, after exclusion of localized lesions like tumors or inhalation of foreign body, including many diseases like like chronic bronchitis, emphysema, bronchial asthma, bronchiectasis, bronchiolitis, and cystic fibrosis. The first four lesions are the most common. The first two lesions called chronic obstructive pulmonary diseases, chronic bronchitis and emphysema. The restrictive diseases characterized by reduced expansion of lung parenchyma with decreased total lung capacity occur in two conditions. The first one is the acute and chronic interstitial lung diseases like acute respiratory distress syndrome and chronic interstitial lung diseases. The second condition is the extrapulmonary disorders like pleural diseases, obesity, poliomyelitis, and kyphoscoliosis. We will start by the bronchial asthma. The definition of bronchial asthma is chronic inflammatory disorder of bronchi characterized by episodic paroxysmal reversible bronchospasm. So bronchial asthma is attacks of bronchospasm due to increased airway hyperresponsiveness or hyperreactivity to various stimuli. Clinically characterized by attacks of expiratory dyspnea, cough, and wheezing. What is wheezing? Wheezing is soft whistling sound during expiration. What are the different types of bronchial asthma? We have two types, atopic asthma and non-atopic asthma. Atopic asthma caused by genetic predisposition to type 1 hypersensitivity reaction. The non-atopic triggered by viral infection, pollutants, or drugs. It is thought that viral infection lower the threshold of subepithelial vagal receptors to various irritants, leading to hyper responsiveness or hyperreactivity of the airway. This table shows the difference between the two types of bronchial asthma, atopic and non-atopic. The atopic asthma is type 1 immunoglobulin E mediated hypersensitivity reaction on exposure to an extrinsic antigen, so we call it extrinsic asthma. The non-atopic is due to or it's a non-immune mediated disease triggered by a number of stimuli in susceptible person. So we call it intrinsic asthma. The age of the atopic occur in the first 2 decades of life with positive family history. The age of a non-atopic occur in adult with no family history. The serum immunoglobulin E and eosinophils in blood is increased in case of atopic asthma, and it's normal in the non-atopic asthma. A person who has extrinsic asthma is also susceptible to develop asthmatic attack when exposed to factors implicated in intrinsic asthma, which are pollutants, viral infection, and drugs. The pathogenesis of atopic asthma, which is type 1 hypersensitivity reaction. The first step is the primary exposure to antigen. This antigen activates the T helper lymphocytes, which secrete different interleukins. After that, the interleukin stimulates the B lymphocytes to form immunoglobulin E, and also activate the mast cells and eosinophils to increase their number. The immunoglobulin E goes to the outer surface of mast cells and eosinophils. And the second step is the exposure to second exposure to antigen. This antigen go to bind with immunoglobulin E on the surface of the mast cells and eosinophils. After that, chemical mediators will secreted, leading to bronchospasm, increased mucus production, vasodilatation, and the recruitment of other inflammatory cells. This occurs in the acute phase. Then the mediators from the eosinophils, leading to exaggeration of the initial response, these responses, plus epithelial damage, and also recruitment of more inflammatory cells. This occurs in the late phase. So we have acute phase and late phase of bronchial asthma. The pathogenesis of non-atopic asthma due to exposure to initiating stimuli like viral infection of respiratory tract or exposure to air pollution and drugs. The viral infection lowers the threshold of subepithelial vagal receptor stimulation to irritant, causing hyperreactivity of both normal and asthmatic subjects, with cellular mediators release causing attacks of bronchospasm. The pathologic features of bronchial asthma. This diagram shows the difference between the bronchial tree in case of a normal person and asthmatic patient. The normal shows wide lumen with thin smooth muscle layer, while in the bronchial asthma, the lumen is filled with thick mucus plug. The smooth muscle layer is hypertrophic and hyperplastic. This transverse section shows the lumen with a thick mucus plug, and the smooth muscle layer is hypertrophic. Occlusion of bronchi and bronchioles by thick mucus plug. So the lungs are over-distended with small areas of collapse due to obstruction by these plugs inside the lumen. Also, the difference between the normal and asthmatic person. This is the normal with wide lumen. This is transverse section of the bronchial tree with empty lumen and thin smooth muscle layer. The asthmatic person here, the lumen is filled with a mucus plug, and the smooth muscle layer is hypertrophic. This is a gross picture of lung in case of bronchial asthma. These are the bronchi and bronchioles filled with mucus plug. This cast of bronchial tree formed of inspissated mucus. This is a normal microscopic picture of the bronchus, lined by pseudostratified columnar epithelium with underlying lamina propria with scattered mucin-secreting bronchial glands. The underlying layer is a cartilage with the outer surface, which is the tunica adventitia. This is also diagram to show the comparison between the normal and the bronchial asthma. The normal here lined by the epithelium with thin lamina propria, thin smooth muscle layer, few mucin secreting glands and cartilage. In case of asthma, the lumen is filled with mucus. The mucus here. and the epithelium. The lamina propria become wide due to infiltration of inflammatory cells with many eosinophils. The smooth muscle is hypertrophied and hyperplastic. The mucin secreting glands show hyperplasia or increase in their number. So we call it air remodeling. This is transverse section of bronchus in case of bronchial asthma. The lumen is filled with mucus plug, and this is the covering epithelium, the respiratory epithelium, with underlying collagen deposition and fibrosis. Increase the thickness of smooth muscle layers and increase the number of mucus glands. The lining epithelium here with underlying lamina propria infiltrated by many inflammatory cells, mainly eosinophils. The lining epithelium here is ulcerated and with focal hyperplasia. The underlying lamina propria show fibrosis and collagen deposition. Many inflammatory cell infiltrate and congested blood vessels. The clinical course of bronchial asthma. The patient suffer from different attacks of bronchospasm with severe dyspnea and wheezing. These attacks last for 1 hour or more, which is relieved spontaneously or by drugs. The bronchospasm causing difficulty in air entrance, then more difficulty in getting air out. Progressive hyperinflation of lungs due to trapped air distal to constricted bronchi that are full of mucus. Then we will shift to the other topic, which is bronchiectasis. This is CT scan of chest showing dilated bronchi and bronchioles here with thickened wall. This disease called bronchiectasis. What is the meaning of bronchiectasis? Ectasis means dilatation and dilatation of bronchi. So we have two parts of the name of bronchiectasis: ectasis, which is dilatation of bronchi. Other CT scan of another patient showed markedly dilated bronchi and bronchiole filled with pus, the whitish area here. The definition of bronchiectasis is a permanent dilatation of bronchi and bronchioles due to destruction of muscles and supporting elastic tissue, resulting from or associated with chronic necrotizing or suppurative inflammation. The patient complains of cough and expectoration of large amount of sputum. We will answer these questions. What is the lesion? What caused such lesion? What are the predisposing factors or associated conditions? The pathogenesis of bronchiectasis. There are two processes involved in the pathogenesis. They are essential and intertwined. Bronchial obstruction and chronic inflammation. The bronchial obstruction can occur due to tumors, foreign body, or excessive mucus inside the lumen of the bronchus. Cause impairment of clearance of the normal secretion, followed by superadded infection causing chronic necrotizing or suppurative infection, leading to more accumulation of secretion, causing more bronchial obstruction. These two processes, chronic infection and bronchial obstruction, causing inflammation throughout the bronchial wall with peribronchial fibrosis and scarring traction on the wall of the bronchi. Dilatation of the bronchi and the bronchioles will occur. The predisposing factors of bronchiectasis. The first one is a bronchial obstruction by tumors, foreign body, bronchial asthma, and chronic bronchitis. Chronic inflammation like necrotizing pneumonia, childhood pneumonia, and TB. The third factor, congenital diseases like cystic fibrosis. In cystic fibrosis, there is viscid or thick mucus and Cartaginer syndrome. In this syndrome, the movement of the cilia is impaired. The gross picture of the bronchiectasis. Bronchiectasis usually occur in the lower lobes of both lungs, so it's bilateral. Show dilated distal bronchi and bronchioles filled with mucus or mucopurulent secretion. Here we have scattered dilated bronchi and bronchioles with intervening lung tissue showed fibrosis. Another case of bronchiectasis. This photo shows the pleural fibrosis and adhesion between the two lobes. Microscopic picture in case of bronchiectasis. This is the lumen filled with mucus, filled with mucopurulent exudate with ulceration of the lining epithelium, and the underlying stroma show areas of fibrosis. The lining epithelium can show squamous metaplasia. Another case of bronchiectasis with dilated lumen here, filled with mucopurulent exudate and lined by respiratory epithelium with focal ulceration. High power showed desquamated epithelium with underlying inflammatory infiltrate, wide areas of fibrosis. The clinical picture of bronchiectasis. The patient complained of severe persistent cough with expectoration of mucopurulent sputum, usually of bad odor or bloody sputum. The cough is paroxysmal in nature, especially in the morning or on changing the position due to draining of the accumulated purulent secretion inside the bronchi and the bronchioles. The patient also can complain of hemoptysis due to ulceration of the lining epithelium of the bronchi and bronchioles. The complications of bronchiectasis. The first complication, which is hemoptysis due to erosion of the nearby blood vessels, could be lung abscess due to secondary infection and localized suppurative inflammation. Pleural complications like empyema, pneumothorax, or bronchopleural fistula. Malignant transformation due to squamous metaplasia followed by dysplasia. Direct spread of infection leading to mediastinitis and pericarditis. Cor pulmonale can occur due to excessive fibrosis and destruction of the lung parenchyma, resulting in fewer alveolar capillaries leading to pulmonary hypertension. Generalized complication like septicemia, pyemia, and pyemia can cause brain abscess. Also, amyloidosis can occur due to bronchiectasis. This scheme or diagram summarizes the complication of bronchiectasis, starting from hemoptysis, pleural complications, lung abscess, malignant transformation, spread of infection from the lung to the mediastinum causing mediastinitis and pericarditis, interstitial fibrosis of the lung causing pulmonary hypertension and the cor pulmonale. General complication, acute toxemia, septicemia, pyemia, brain abscess, and amyloidosis. Now we know the definition of bronchial asthma and bronchiectasis. We explain the pathogenesis of each one. We describe the pathologic features of each, either gross picture and microscopic picture. And we know what is airway remodeling, and we listed the complication of bronchial asthma and bronchiectasis. Thank you.